Hello, my name is Dr. Deborah Cohen, and I am the MAVEN Project volunteer moderator today. Thank you all for joining us, and our friends at Mariposa Community Health Center in Arizona, who are our anchor clinic, and they are hosting today's session, which is Too Tall and Too Small, When and How to Evaluate Growth by Dr. Laura Bachrach. Dr. Bachrach is professor of pediatrics in the Division of Endocrinology at Stanford University School of Medicine, where she leads the Pediatric Faculty Mentoring Program and co-directs the Pediatric Bone Health Program. And with that, Laura, please begin.
Good morning, everyone. I have to tell you, this is my maiden voyage into giving talks for MAVEN, and I'm very, very excited, and I'm very grateful to have people joining this discussion. I will quickly move through the slides. I must say that basically I have nothing to disclose or confess. Well, my husband might not agree with that, but nothing official. And the accreditation you're familiar with. I think it's really important to discuss growth because it is a barometer of overall health in children. The variability is very challenging, and you know from your practice that parents really focus on it. You know, the first thing they want to do when you get in the office for a well child visit is, hey, what percentile is he growing? These are the official objectives to talk about normal and abnormal growth patterns and trying to distinguish between the two. And it is hard because the variation is challenging to evaluate the possible causes, not only the endocrine causes, but non-endocrine causes as well. And think about how to use clinical assessment tools like lab work and bone ages, et cetera, and then talk about, when to initiate treatment for growth problems. The factors regulating growth are myriad, and it isn't all hormones. Genetics is a big factor, and you'll hear me talk about this in a moment. There are several hormones involved, but then you also have to have adequate nutrition, an adequate psychosocial support system, and a normal metabolism. The endocrine causes of growth or regulators of growth are myriad. We always think about growth hormone mediating its effects through the peripheral insulin-like growth factors that we call IGF. So that is an important regulation of growth. But the reality is that abnormalities in that axis are much less common than problems with thyroid. So TSH affecting or regulating T4 and T3, abnormalities in the thyroid hormone system are much more common than growth hormone deficiencies. LH and FSH then causing puberty hormones to go up. They're critically important as we talk about the interaction between growth hormone and the sex steroids at the time of puberty. Another growth hormone you might not think about is insulin. So insulin is a very powerful growth factor. We think about this, I'll talk in a moment, about infants of diabetic mothers. Those infants have high insulin levels, and that's why they overgrow. And I wonder whether some of the obese children that grow faster, at least early on in childhood, it's in part because of their insulin levels. Glucocorticoids in physiologic amounts, cortisol in physiologic amounts, they're fine for growth. But we see many children who are on high dose glucocorticoids. So if you get into the high range of glucocorticoids, that's when you get inhibition. So most of these things shown on the slides these hormones are stimulating growth. Glucocorticoids, an inhibitor of growth, at least in high dose. So my general approach when I'm walking in a room and I know it's a question of growth, my first question is the child short? And that may seem like a silly question, but every parent wants their child, well, many parents want their child to be shorter, and they're comparing their child to everybody else in the kindergarten class. So is the child short? What's the definition? Are they growing normally? And those are two distinct questions. Okay, the first question, what is short? You can use a population standard, which is basically say less than 2 standard deviations, below 2 standard deviations. That would be the lowest 2.3 percentile. I don't particularly like that because it sort of ignores genetics. So what you really want to do is say, is this child the normal size for the family or small for the family? Sorry. And so to do that, to answer that question, we do something called a mid-parental height. And I do this every time I see a child for a growth issue. So how do we do this? We take into account that men, on average, when they're fully grown, are 5 inches shorter than women. That's just the biology of the situation. So if we have a boy and he's coming in, the family says he seems very short. We take dad's height as it is and mom's reported height and give her 5 inches, because if she were a male, theoretically, she'd be 5 inches taller, and divide that by 2. Conversely, the midfrontal height for girls, to take dad's height and take away 5 inches and take mom's height and divide by 2. And the child, this is the average for the family, okay? And the child should reach that height, or expected to reach, if everything's going well, reach that height plus or minus 4 inches. So it's not that they're exactly going to get there, but within that 4 inches of a range. The other thing I always consider is, are they growing normally? And growth rates vary a lot. In the first year of life, children grow an astronomical average of 10 inches. Obviously, that doesn't continue throughout childhood. From most of childhood, age of 5 till 12, children should grow an average of about 2 inches or 5 centimeters per year. That's the average. Now, then you hit puberty, and the growth rates go up. At their peak, boys grow around 4 inches a year and girls around 3. Now, puberty really does complicate things. Now, both of these children in this picture are normal. And if you decide to join me later on, we'll talk about early and late puberty. But both these kids are normal. But the girl is 14, she's done her growing. The boy is 14, he's a late bloomer. He hasn't started to grow. But of course, the parents are freaked out about this young man. So pubertal timing, this was traditional teaching. I'm not going to spend much time on it, but basically girls start around 10 traditionally, was the traditional teaching. And as soon as they get the breast bud, they begin to get the growth spurt. Boys start about a year and a half later, and they're further into puberty. They're not Tanner stage 2, they're Tanner stage 4 or so before they really grow their fastest. And that's what leads to the discrepancies that you see in middle school that are so distressing. This shows you basically what happens. Girls start their growth spurt earlier in puberty, and it's less robust. As they say, they grow around 3 inches a year versus the boys. Boys start later, they have longer to grow before puberty, they have a more robust growth spurt, and that's how they end up this 5 inches taller than the girls. So normal growth would track along the curve with an exception, and that the exception is during the first 2 years of life, where there can be a lot of movement on the growth curve. Catch up or catch down growth can be normal. Let me show you what I mean. So these are discordant twins. The one in the bottom obviously got the short end of the placental stick, so to speak, ended up significantly smaller than the other baby. That child has SGA, small for gestational age, and the facts are that 85 to 90% of those children will catch up by the age of 2. That means to 10 to 15% of SGA babies will be small children. So we do know the majority of children will have catch-up growth, but some will not, and that is a potential indication for the use of growth hormone. Now, this is a baby we expect catch-down growth to happen in the first 2 years of life. This baby is the infant of a diabetic mother who unfortunately had inadequate control of her diabetes during the pregnancy. So therefore, the baby was hyperglycemic. The baby put out a lot of insulin and had the overgrowth that you see here. That baby genetically is not destined to be huge forever and will have catch-down growth. Okay, so after the age of 2, when you see a child who's either crossing percentiles upwards or crossing percentiles downwards, to me, those are the ones that require particular evaluation. Let me show you what I mean here. If you can watch the slide for a minute, I don't know how well these dots show up. But this is a child who comes in, the parents are worried about short stature. But what you can see is there's been very steady growth velocity. And I would ask you about midparental height, and it turns out perhaps this is all fitting for this child. This child comes to see me for a visit is at the 50th percentile for height. So theoretically, not even short, but a very worrisome from my perspective growth curve because of the changing growth percentiles downwards. So that's what I'm talking about, looking at not only where you are on the curve, but kind of how you got there. The causes for short stature, the normal causes are the majority. Okay, familial or genetic short parents, short stature, where you have short parents, a normal birth history, normal birth size, and normal growth pattern, this child will be short as an adult. The other normal variant that is pretty common is so-called constitutional delay of growth, which is what you call a late bloomer. It's that slide I showed you, that boy at the 8th grade dance. In this situation, the parents are not short, but when you see the child and you look at where they are, let's say the parents are on the 25th percentile for height, midparental height, but the child is at the 5th. The parents are not short, so the child seems discordant for the family. The child typically would have a normal growth rate after the first 2 years of life, might have slowed down in the first couple of years, but then should be paralleling the curve. And they have a later puberty and they catch up at the other end and end up with a normal adult height. This is a graphic that shows what I'm talking about. This is a child who is tracking basically along about the 5th percentile. And things get worse before they get better because the other boys in this situation are having, or girls, either way, but they're having their growth spurt. The boy or girl has not yet had his or hers. So the distance between the late bloomer and the normal population gets worse. But you can see then, instead of stopping at the normal expected age, this child will continue to grow longer and the catch-up occurs there. But this can be very, very hard for these young people to sort of live through being a late bloomer. But it's important to distinguish what's normal from what's not normal. There are several non-endocrine causes for short stature, and I'm going to flip through some slides just to tell you what I think about when I see somebody. Skeletal dysplasias, we'll talk about that. I'll show some pictures that are genetic or chromosomal abnormalities. The intrauterine growth retardation, I mentioned that. This is the 10 to 15% of children that are born small and don't catch up. And then, of course, a whole host of chronic diseases where children grow very poorly, either because of the disease themselves or the toxic medications we have to use to control the disease. So here's an example of a skeletal dysplasia. The hallmark of a skeletal dysplasia is they have disproportionate short stature, right? So in this case, you can see that the upper arms, the limbs are shorter than expected for the trunk. This is disproportionate short stature. And these children, definitely will end up short as adults, but the marker is the disproportionate short stature. Growth hormone has been attempted, not very successfully, to treat these children because this is just an ingrained problem with the skeletal dysplasia. There's new medication out there that has just been approved by the FDA. We're really learning how much this is going to add to final adult height, but it's not an endocrine problem. It's a genetic problem. This is an example of a genetic problem, Turner syndrome, where you're missing all or part of one of your X chromosomes, affects 1 in 2,000 females. And you were taught from your textbook that they have a webbing neck, increased carrying angle, shield chest, but I want to point out they may look entirely normal. And this is a family where the kids lined up in age order. So you'd expect them to be height-wise lining up. And you can see the young lady in the red sweater doesn't cut it in terms of height. And she actually was followed for some time here at Stanford and was going to put into a study for normal variant short stature until somebody realized, hey, maybe we should do a chromosome analysis. So she did have Turner syndrome. Short stature is a cardinal feature. 100% will have relative short stature for the family. 96% will have problems with gonadal failure. But if you wait to find or screen just those with webbed neck, you're going to miss 75%. Increased carrying angle, you'll miss half of them. So you basically have to consider Turner syndrome in any girl with unexplained short stature for the family. There are 3 causes of endocrine short stature. the most common of which for sure is hypothyroidism. This is a 17-year-old that I took care of, and at age 10, she had presented to the orthopedic surgeons for a slipped capital femoral epiphysis, which is associated with hypothyroidism, but the orthopods were doing the fixing of the hips, not doing any endocrine workup. But the reason they finally referred her was because her growth plates were still open at 17. And you can see what her growth curve looks like. She had a very, very abrupt fall off in height, but none of the classic symptoms that you'd expect for hypothyroidism. Children do not always complain. Growth failure always with acquired hypothyroidism if it's in a time when the growth plates are still open. But the other signs and symptoms are very, very variable. They don't necessarily complain like older people do of constipation, fatigue, dry skin, and so forth. They may not complain, but it's something that always has to be considered when you see a growth pattern like the one I showed you. Growth hormone deficiency, as I've said, is definitely less common than thyroid disorders. These two boys are the same age. What you see about the little guy on the left who has growth hormone deficiency is not only is he shorter than his friend who's the same age, but he has a sort of cherubic look. Body composition is different in growth hormone deficiencies, a tendency to be more sort of body fat, less lean body mass. The workup, obviously, we'll talk about it in a minute. Glucocorticoid excess is the third one we always think about. This unfortunate young man has an endogenous overproduction of glucocorticoids, and you can see these, he's getting some endocrine testing, that's why he's got his ID in place. But the majority of children that I see that come through my clinic that look like this, it's because we're doing it to them. There are children who are having high-dose glucocorticoid therapy for inflammatory bowel disease, for rheumatologic disorders, for transplant, for Duchenne muscular dystrophy, all sorts of reasons. So iatrogenic glucocorticoid excess, very, very common and very, very powerful negative effects on growth. And the hallmark here is you have the growth slowdown, typically with weight gain. Okay, so I really worry about that. If you see somebody gaining weight a lot, the majority of times it's because they're basically overdoing the McDonald's, but they also typically have an accelerated growth rate in terms of height. But if you see weight gain and a growth slowdown, that definitely is a worrisome combination. I want to say a couple things about tall stature because every once in a while, tall stature is concerning. This is the famous Alton giant, who, as far as I know, was the very tallest of people that have been recorded. And again, this was growth hormone excess. But again, let's think about tall stature. Two ways to think about it. You can be tall because you've always been tall, probably have tall parents, and that's the way it is. Your growth rate is normal. Or at a given moment in time, you could be tall because you've had accelerated growth. And the accelerated growth, of course, as you can imagine, are the ones that I'm more concerned about. People crossing percentiles upwards as well as downwards need to be thought about. So tall without accelerated growth, those are familial or genetic tall stature, tall parents, tall child. But there are some syndromes, Marfan syndrome, autosomal dominant, I'll show you a picture in a minute, Klinefelter syndrome, 1 in 800 males with an extra X chromosome, 47XXY, or homocystinuria. Here's a mother and daughter with Marfan syndrome. What you see is they're both tall, and you have these so-called arachnodactyly, sort of long, spindly fingers. Aortic root abnormality is very important to figure out because it can be a source of significant morbidity. An ectomic lens of the eye, and of course the tall stature. So the ones I worry about, tall with accelerated growth. Now this can be normal. It can be normal, exogenous obesity. So the 5-year-old who is wearing size 10 clothing is because his BMI is high. He's got high weight, high height for the family, for age. Those children do not end up taller in the long run. Precocious puberty would want to worry about. Less commonly, congenital adrenal hyperplasia, hyperthyroidism rarely, because unlike hypothyroidism, those children are usually very symptomatic and they get picked up before they can get tall, but you can have accelerated growth with that. Growth hormone excess is rare, and this cerebral gigantism, a genetic disorder, is rare. Exogenous obesity, you see a lot of this, I'm certain, in your practice, as I do in mine. Weight greater than height percentiles, and they are tall and overweight. They end up with a normal adult stature. They don't get to be taller in the long run. They kind of just do it sooner. Precocious puberty, definitely want to think about either complete precocious puberty with breasts and pubic hair in the female, and testicular enlargement, pubic hair in the male, or partial from adrenal excess. Again, if you feel up for it, we can talk about puberty another time. These children will be short as an adult if not treated, so you want to pick it up. And then gigantism is rare. We talked about crossing percentiles from growth hormone excess, very, very rare. So that's a lot of background. What I really like to do is to practice the cases. So let's do some real cases that come from my practice. Before we do that, my systematic way of thinking about it is to ask or think about the patient. What was the birth weight? What was the length? What were the growth rates like? And has there been any illness or medication? What are the heights of the parents? And what is their timing of puberty? Now, to get at that, I asked mom how old she was when she got her first period, and to find out about when dad reached his final height. Men don't have this sentinel event like a first period. I'm going to stand up 1 minute because Stanford turns off my lights if I don't move, and I'm in the dark. We are so environmentally correct here. Okay. So the exam, I focus on pubertal staging, look for dysmorphic features, including webbing of the neck, heart murmur, single central incisor, body proportions, that sort of thing. Okay. The growth labs to consider, and I don't always order all of them at once, but it would be thyroid levels, insulin type growth factor type 1, and IGF binding protein 3. I do not order a random growth hormone level unless I'm worried about growth hormone excess. Random growth hormone levels kind of don't make any sense because growth hormone is secreted in an episodic manner, pulsatile manner, mostly during sleep, and things can suppress it like eating breakfast. But the IGF-1 and the IGF binding protein 3 that are regulated by growth hormone, fortunately have normal levels or stable levels throughout the day. Sex steroids occasionally if I'm worried about early or late puberty, and I rarely get an evaluation for glucocorticoid excess. Non-endocrine tests go through my mind, especially if I'm thinking this could be a non-endocrine cause. CBC SID rate, a celiac screen very commonly, because celiac disease may cause growth slowdown even in the absence of significant GI symptoms. So you do put that high on the list, making sure kidneys and liver are working fine. And then my indications for doing a chromosome analysis would depend on my suspicion of either in Turner syndrome, and of course in tall stature, thinking about Marfan's, not Marfan's, Klinefelters. What about a bone age? If you can look to up to date, it's wanting you to do a bone age all the time for things. It's most useful after the age of 5. I definitely do not do a bone age under the age of 2. You really need to do what they call a hemi-babygram to get enough of the growth plates to make any sense of it. Most useful after the age of 5. Consider it if a concern for early or late puberty. The only reason I struggle with it a little bit is whether it's early, late, or normal. I'm not sure how that is going to help me understand what happened. It might tell me the growth potential, but it doesn't tell me the why part of it. But we can talk about that later. Now, the treatment will depend on the cause, correct endocrine deficits or excess. Of course, look at chronic illness and address that. Slow precocious puberty, potentially jumpstart delayed puberty. And of course, consider therapy for the new therapy for achondroplasia. I'd say one thing about growth hormone before we actually plunge into these cases. Parents ask about growth hormone, even if you tell them your child is normal. They say, well, what about giving my child growth hormone? Wouldn't that help? These are the FDA-approved indications for growth hormone deficiency, Turner syndrome, renal failure, growth failure in the setting of renal failure, and a small for gestational age child who has not caught up by the age of 2 to 3. So those are official ones. Normal variant short stature, theoretically, you could get approval for, but it's very, very difficult. And what you have to understand is that although 70% may grow faster on the treatment, the gains in final height are pretty modest. For every year that you give a shot every day of growth hormone, you gain 1 centimeter for every year of use. And we're concerned about late side effects. So it is something that parents ask about, and I have to be prepared to talk about the pros and cons. Okay, so here I am going to launch into what would you do? Okay, so here's the case. This is a camp physical. This is an 11-year-old girl. That's all the reason she's coming in. She comes in about, as you can see, about every year, year and a half to get a camp physical. She has no complaints at all. The mid-frontal height is 5 feet 4 inches tall, which is about the 50th percentile. And her exam is unremarkable. And she's seeing a new physician for the first time. And this is the growth curve. So what would you do at this point? Unfortunately, at this point, because I'm new to this MAVEN system, I haven't got the fancy dancy, what would you do? But just ask yourself, which of these, and you're allowed to pick more than one, which of these tests, if any, would you do? And I'll go back to the curve for a minute. Which would you do for this 11-year-old girl? Would you do a bone age? Would you do a chromosome analysis? Would you do thyroid and growth factors? Or would you just observe in 6 months?
Laura, would you like people to put their answers in the chat and I can read them back?
I'm happy to do that. I know you're watching the time better than I don't actually even have a clock here. So I've got 3 cases. So if people want to just plug in for a minute.
I think we've got plenty of time. So if you all would like to answer in the chat, and if that doesn't work, Laura, then you can just go on. Let's see, not getting any responses yet, but it takes a minute.
People might be drinking their coffee. That's okay. That's
You-
okay. Well, here I'm going to suggest, and we can get ready for the next one, but maybe do a bone age. I'm not saying it's wrong. In that situation, parents might say, oh my gosh, is it too late? Has my child already finished growing? I mean, of course, the physical exam would tell you that. The physical exam shows somebody who already has fully fledged breast development and menstrual cycles. You know that that may be a child who you missed the boat earlier on. She had precocious puberty, early growth spurt, and then leveled off. But that's not what you saw in exam. So maybe do a bone age if it would reassure the family. I would not do a karyotype as the first step, but that's just me being frugal. To be honest, I have sort of in my mind a staged approach to doing testing. So I would go ahead right away with thyroid levels, and I would do the growth hormone levels. Now I realize the thyroid hormone deficiency is going to be the most common, but I don't particularly like to stick kids twice. So I'm going to order, in addition to my thyroid levels, the IGFs. Observe in 6 months? Absolutely not. Absolutely not. In this case, turned out to be somebody with primary hypothyroidism. Again, I struggle with this because this child came from a practice within 5 miles radius of Stanford. It would be very easy for someone to pick up the phone and ask the question, what should I do? I also don't like to wait till somebody is certifiably short. At the point where she went from the 50th percentile to the 25th percentile, maybe I would say that just is a little growth variation, measurement error, whatever, whatever. But instead of waiting a year and a half to see her again, it probably would have said, let me see you back in 3 or 4 months. Okay, but they didn't. They came back a year and a half later, and now she's certifiably short, but still nothing is done until the new pediatrician came along. And I think that was because she was asymptomatic. So that's my lesson there. So takeaway points, please don't wait till the child is certifiably short. But labs confirmed that there was asymptomatic hypothyroidism. We treated, but the child never regained the full height potential that she had because of that long delay. Now, this is a boy who comes in with dad, and mom's busy at work. And so dad's providing the history, and he doesn't have much to say about this child, except that he's very upset about being the shortest on the soccer team. And it's only with very careful probing do you get any history of diarrhea or cramping. The boy doesn't bring it up. The dad doesn't know. As we know, sometimes the moms know almost too much about kids' bowel habits, but mom's not there. So it's only when the pediatrician asks very carefully, do you ever get, stinky poops? You have to be the one to do that. Do you ever get tummy cramps? And he reluctantly admits that that's been going on for a while. He's thin and he's slightly pale. And you can see he definitely has had a growth slow down. So what would you do in this situation? Bone age, to send him to endocrinology, you do his labs, all that maybe, but definitely high on the list. This looks like a non-endocrine problem. And again, doing the endocrine testing is perfectly legitimate, even though your primary worry at this point is this sort of failure to thrive and chronic look to him. But you could reasonably do the thyroids and IGFs at the same time. The only caution here is the IGF-1 level, the insulin-like growth factor type 1 level, is affected by nutrition. And in somebody who is significantly underweight or undernourished, this could be your girl with anorexia nervosa, it could be your child with Crohn's disease. IGF-1 can be low on the basis of that. IGF-BP3 is less affected by nutrition than IGF-1. But again, I think it's reasonable to think about doing the workup yourself. I would not start by referring to endocrine because I think this is probably going to be a non-endocrine disorder. So not all growth slowdowns are endocrine. The GI symptoms can be hard to elicit. And the workup, again, now these factors. Now here's a girl that's growing too fast, 6.5-year-old, clearly growing too fast, crossing percentiles. And the mid-parental height here is at the 25th percentile. So you can't say, oh, she's, it's just a tall family. What would you do? Refer to endocrine, get growth hormone and IGFs, do an LH and estradiol, get a bone age. Again, the crossing percentiles upwards is very concerning. Careful exam here. Does she have breasts, pubic hair, and acne? Because I think that's definitely something that would be high on my list, higher on the list than growth hormone excess. And the exam is going to help you a lot. The exam is going to tell you whether you think this is precocious puberty affecting the hypothalamic pituitary ovarian axis, that you're going to get estrogen going up, with or without androgens from the adrenals, or isolated adrenal excess androgens if you have congenital adrenal hyperplasia or an adrenal tumor. There, you just have adrenal hormones coming out and they can accelerate growth. They would give you pubic hair, acne, perhaps underarm hair, body odor, but no breast development. So the exam tells you a lot. Growth hormone excess way down the list in terms of frequency, and the exam tells you a lot. So if there's breast development, I would get an LH, FSH, and estradiol. If there's pubic axillary here, I would do the adrenal hormones. 17-hydroxyprogesterone, testosterone, androstenedione, and DHEAS. Bone age is optional again, and parents may ask for it. Up to date will tell you to do it. Again, I struggle with it a little bit because it doesn't change my management, whereas the labs do. And the treatment, of course, will depend upon your lab tests. Here's a 14-year-old starting high school. He desperately wants to play football, but he's going to go to a large competitive high school, and he knows he's too small. His review system is entirely negative. His mid-parental height is at the 25th percentile, and he's only at the 5th. So what are you going to work up for him? What are you going to do for him? You're going to follow him up in 6 months. You're going to get a bone age. You're going to get his puberty hormones. You're going to get his thyroid and growth hormones. Let's go back and look at it. And here's the choice. His growth rate is normal, but less than expected for the family. So you assess his pubertal stage. So you do the labs. Looks like he's in early puberty at best. He's got an LH of 0.4, which is like very whiff of starting puberty. His testosterone is 80, a little whiff of puberty, because less than 10 is prepubertal. His bone age is done because the parents are really concerned, and his bone age is delayed. So here's a situation where I would reassess in 4 to 6 months and not do anything, but you could really, really reassure this boy. Now, if you'd done his LH and it was prepubertal and his testosterone was prepubertal, at that point, I would offer him a jump start. And again, if you end up coming back for more and talking about managing early and late puberty, we can go in more detail with that. But in this situation, your lab testing and your bone age are going to be very reassuring to this young man. That, is frustrating as it is going to happen. And I wouldn't do any in terms of treatment. So you are growth experts at this point, and I decided to throw in one really challenging case because I think we've got the time, and then we can do some questions. This is an optional challenge. This is a challenge that came to me, and I love to show it because it brings up some important points. So this was a 14-year-old came in with mom who was always concerned about her child's height, always concerned that it had been short. She had started puberty. She had breast development. She had some pubic hair for sure, but she hadn't yet started her menstrual cycles at 14. The parents are tall. If you do the midfrontal height on the parents, they're at the 90th percentile, and she'd had breast development now for a couple of years, but still no period. And mom had started her periods at 12. And mom's agenda, I can tell you her agenda, was I want my daughter to get growth hormone. So what would you do? Refer to endocrine? Well, mom did. I mean, mom did get the referral, so there I was. But what would you want to think about doing on your own? Let's say you are 1,000 miles away from endocrine and you haven't heard of MAVEN yet, because MAVEN's going to take this on and really appreciate hearing from you about this case. Would you just decide you're going to get thyroids and growth hormones? You got bone age? Are you going to do puberty hormones? Think about this one. I'm going to leave it on for a minute because I'm going to remind you of all the features. She's definitely in puberty. She hasn't been growing well. I mean, she's growing at a normal rate, but well off for the family. So what are we going to do? What are we going to do here?
Why don't we put some answers in the chat if you'd like to throw out something, and I'll read them off.
Okay. Because this is not an easy case. I mean, I'm not giving you the easy ones. This was and I'm going to tell you my approach because I do, again, try to do a cost saving systematic approach.
Anybody have any ideas that you'd like to throw out there? One of our participants says she would definitely do thyroid labs.
Mhm.
Consider Turner syndrome, but start with thyroid and IGFs.
Mhm.
Anyone else? These are great answers. That's all we have for now, Laura.
Okay, well, there's a brave and sharp person out there, very brave and sharp, whoever she or he is. Okay, so I did really do the workup. I didn't refer to endocrinology. I was the endocrinologist, but I agree with doing the thyroids and the IGFs. That's part of the standard thing. And I threw in the puberty hormones because this is my poor man's screen for Turner syndrome. Okay, so the thyroids and the IGFs were normal. The FSH actually came back the next day. The other thing I liked about doing the puberty hormones as opposed to a karyotype as first step with Turner syndrome is that at that age, the FSH is going to tell us whether this tornado, the FSH was in the menopausal range. I literally got this back the next day. So the thyroids and IGFs were normal. The FSH was very high. The bone age was 12. So I called mom and I said, I think your daughter might have Turner syndrome. And she was irate. She was furious. She said, oh, no, she can't have a Turner syndrome. Girls are ugly and they're stupid and all these things, this stereotype. And I said, no, I think it's real. So she insisted I repeat the FSH the next day, which I did, and it was still there. And at that point, I ordered the karyotype. And she had a Turner syndrome, mosaicism, that definitely was the explanation. So I did treat her with growth hormone initially, and held off on the estrogen initially because mom's priority was to have her grow more. And the girl, as they say, had breast development, but hadn't had her period, but she wasn't all hot and bothered about having a period. So we started with growth hormone alone. We wanted to give her a little more time to grow if we could. Unfortunately, in our workup, we found out that she had some Y chromosome material in her karyotype. She was a mosaic, but she had some Y chromosome material as part of her Turner syndrome. So she had to have her streak ovaries removed and she had a gonadoblastoma in situ, and we had to stop her growth hormone. Fortunately, she did well from that standpoint and we were able to start the estrogen. But my takeaway point here is, and whoever, again, was up there with their coffee and their good, I thought, this is something we have to consider, even though she's now 14, but you see, what you can see is that she's grown short. She's been relatively short for the family, basically all of her life, and never got worked up, which would have been appropriate. And so we're not going to be able to help her much in terms of her growth. So that ends my thoughts. I will stop sharing my screen and hope there might be some discussion here.
Yes, thank you, Laura. That was such a clear and concise presentation about short stature. We really appreciate that. And you do have a couple questions. One question is, does vitamin D deficiency affect the growth of bones?
That's a great question. Vitamin D, well, first of all, let's talk about what we mean by vitamin D deficiency. Okay. So the lab tests, the commercial lab tests will vary in terms of what they say is a normal range. Some of them set as a normal range as high as 27 or 30. And the reality is that pediatric data indicate that if you have a 25 hydroxy vitamin D level of at or above 20 nanograms per ml, 20, not 30, not 26, but 20, that you are physiologically replete. Okay, so vitamin D deficiency or insufficiency is defined as less than 20. Deficiency, where you're actually symptomatic with rickets and high alkaline phosphatase and that sort of thing, typically is a level of less than 10 or 12. So insufficiency, if you've got a 15, 17 level, you're insufficient, but you're not deficient. I do address that, and that's something else we'll talk about if you want to come for the bone talk. But no, the answer is no. Now, if you have florid vitamin D deficiency rickets, yes, it will affect growth. It causes, as you know, bowing of the legs. It causes ratty looking growth plates and so forth and so on. You can get short stature on the basis of flagrant vitamin D deficiency rickets, but I rarely see that. I do see a lot of people. It's recommended that an otherwise healthy normal child, to be honest, is the otherwise healthy normal child should not get a random vitamin D level. It's just not helpful. These are official recommendations. Every child should be on vitamin D. The American Academy of Pediatrics says the first year of life, every child should get 400 international units of vitamin D. And after the age of after the age of 1 until forever, you should have 600 international units of vitamin D a day. And that's recommended for everybody, including adults, and older women actually need more. So I think everybody, rather than doing the vitamin D level, unless you suspect a condition that's symptomatic, then you should just say, hey, let's just get you on vitamin D. Again, we'll talk about that at a future time, but people say, well, I get sunshine, but if you put even SPF 8 on your body, which you're supposed to do when you go outside, you're supposed to use SPF 30, then you will block 95% of the rays that allow you to make vitamin D in your skin. Vitamin D deficiency, profound, yes. Short stature, generally, no.
Okay, thank you. And I would say also that on the community portal, we have pearls about vitamin D replacement in children. So that's available to all of you on the portal. I'd like to go to another question, which is, does IBD cause growth issues like celiac disease does?
Absolutely fantastic question. IBD is very, very concerning for growth and bone health. It's a chronic inflammatory condition, can definitely affect growth in itself. And again, some of it is mediated through the undernutrition, which in fact can result in low IGF-1 levels. But yeah, and then sometimes the glucocorticoids that are used to treat IBD definitely can cause further problems with growth. Fortunately, we've got more of these biologics now, so we're using less in terms of glucocorticoids, but absolutely it can cause significant growth failure. And it's always on my list when I see someone with short stature and GI symptoms. I'm thinking, this could be a non-endocrine case. Just because they're in endocrine clinic doesn't mean that they got an endocrine problem. And I have been able to make the diagnosis of IBD myself or celiac disease in my clinic.
Right. Okay. Another question is, at what level of vitamin D do you see rickets? I believe you've already answered this. I've seen a vitamin D of less than
One
4.
thing to that, I'm going to add one thing to that, and that is, there's two causes of rickets. One is vitamin D deficiency and one is calcium deficiency. And if you have a low calcium intake and a low vitamin D, you may see symptoms or signs sooner than if you just have one or the other, right? And so, for example, there are parts of Africa where they don't see much in the way of vitamin D deficiency, but they have a low calcium diet. And you can get rickets on the basis of that. So I want to always mention that the two of them go hand in hand. When we think about that. And I guess the cases I've seen that have been most extreme, I have some children with autism who are on extremely bizarre diets. They only eat French fries and Pop-Tarts, right? And I've seen scurvy, and I've seen definitely vitamin deficiencies in that population.
Okay, thank you. Do inhaled steroids in asthma patients affect growth, or do steroid nasal sprays affect growth?
These are fantastic questions, I got to tell you. I'm not too concerned about the nasal sprays in high dose. The high dose, excuse me, inhaled glucocorticoids, they have much less of a systemic effect, of course, than the oral ones. But in very high doses, there are reports in the literature of two things that can happen. Number one, growth slowdown, and number two, suppression of the body's own ability to make cortisol. So you can get a iatrogenic adrenal insufficiency, but that's really, really on the basis of very high doses used chronically. So most of the time it's not a problem. And of course, if you're trying to choose between breathing and growing, you choose to breathe. But no, it's uncommon, but I won't say never, that it could impact growth and endogenous production of cortisol.
Okay, great. Our last question for now is, does low is low calcium intake assessed via diet assessment only? Is that correct? And a calcium level wouldn't help in that situation. Is that right?
Great questions. Again, absolutely great questions. The blood calcium level is the last thing to go. if you have a deficiency. It's the last thing to go because the body needs this certain calcium level to maintain the electrical system and the muscles and so forth and so on. So you have all sorts of counter-regulatory mechanisms in your body to take the calcium out of bone. If you're not getting enough intake, or you can't absorb it, or you're having excessive secretion, your body wants to maintain this calcium in a very, very tight range. And what will happen is if your calcium begins to dip because you haven't had enough to eat, you're losing it in your kidneys or whatever, your parathyroid hormone, your PTH will go up and resorb calcium from the bone. Okay, so the level of calcium in the blood is the last thing to drop. So it's not helpful at all in terms of being a particularly sensitive marker of the deficiency. There are ways of looking at this. Certainly, if you measure the PTH level, which would be high in calcium deficiency, as the body's trying to compensate. If you have a low dietary intake, something the adultists do is they do a 24-hour urine collection for calcium creatinine. I don't know if you've ever tried to do a 24-hour urine collection on a child. It's hard enough to get an adult to do a complete collection, but the adultists do that. And if they see a low level, they think one of two things. Either there's inadequate intake or inadequate absorption. If they see a high level of calcium in the 24-hour calcium creatinine ratio, then they say, well, there's an excessive loss of calcium from the kidneys. So they use that a lot to sort of look at calcium metabolism. You can do a spot urine sample, spot calcium creatinine ratio, but to be honest, it's just a little quick moment in time. I'm gonna get my light on here. It's just a quick moment in time, and I don't think it really helps you that much. So I would say I would take a good dietary history in terms of the calcium intake. And just to know that the majority, 70% of calcium in the American diet is coming from dairy products, 70%. Now, the kids that don't drink milk, which is the majority, if you're using plant milk, those are supplemented, so there's good sources of calcium in that. And then there are some non-dairy sources like almonds, bok choy. People say, oh, it's broccoli. Well, you need 2.5 cups of broccoli to be the equivalent of 1 glass of milk. And children are supposed to be taking the equivalent of about 3 glasses of milk a day. So there's no way you're going to have 7.5 cups of broccoli going into a child, and that's their source of calcium. So there's a lot of inadequate calcium intake. And again, this is something that I love to talk about. And if you come back later for the talk about bone health, I'm going to go through in boring detail, I think, all the issues of calcium intake and what affects the absorption and retention and so forth, and how can we build the healthy bones in our kids. But typically, in terms of growth patterns, I'm not seeing kids not growing because they aren't getting enough calcium.
Okay, and maybe this will be the last question. Is the ability to absorb calcium limited to 500 milligrams at a time?
Another great question. I mean, it's generally thought it's best to distribute your intake. So if you've got somebody, taking theoretically 500 to 600 milligrams at a day at a time is thought to be sort of the best amount. I want to say one thing about calcium loss and something to consider. Sodium salt causes calcium loss. So when you excrete excess sodium, let's say you've had go to McDonald's. Okay, you go to McDonald's, you're feeling very diligent because you've got your child. They're ordering the fries, they're pouring on the salt, but they got a carton of milk as well instead of juice or soda, which is what you want. So you're feeling very good. You had your child take 8 ounces of milk, but the ton of salt on their fries. You have to be aware you are counteracting the benefits of one with the other. So salt inevitably causes loss of calcium in the urine. It's a biochemical reaction that it takes it out. So ideally, we want to minimize the salt in the kids' diet. I'm not saying low salt, but try to minimize the added salt for many, many reasons, but one of which is that it does tend to drag calcium with it. So try if you're at McDonald's, try to lose the salt shaker. They can add ketchup instead. Get their vegetable or ketchup.
Okay, and Laura, do you know when your bone health talk is?
Yeah, I should be able to figure that out. I should just look at my calendar.
I'd like to remind you all that in addition to these educational sessions, as I'm sure you know, we also offer our electronic medical consultations with our volunteers. We have over 200 volunteers in more than 60 specialties here at MAVEN. And also we have a very robust mentoring program, and there's both leadership mentoring and also clinical mentoring. For those of you who are new to the clinics and might like to get some advice about clinic flow and handling patients, we talk about burnout, all different kinds of things, and these can be serial visits so that you can have your own personal coach.
I'm going
And
to pull out something from my files. I love bone questions. And I am new to the MAVEN consult team, but a very enthusiastic. I love questions. I love them. They're like puzzles to me. And I really actually prefer them to lecturing. So I'm just trying to find my sheet here. I think I know it's the third one and it's coming up in later in the year, but in the meantime, got a question for me about bones or puberty or anything else endocrine. I love it.
Muriel, for you, I will go ahead and find out when that bone talk is and shoot you an email about that. So we can do that later.
Okay, I do apologize. I should know it off the top of my head, but I don't.
No, it's perfectly fine. And let me see. Yep. Okay. I think that's it with just a minute to go for the top of the hour. And I want to thank Dr. Bachrach so much. It was a great talk with discussion, and we hope to see you again at more MAVEN seminars. I know, Laura, you have a few coming up, so we look forward to that.
Okay, but please shoot me the questions. I did see one more in the chat, and that was, is lead resorbed when calcium is resorbed? That's a super question, and I don't know the answer, but I would not necessarily think so, because the mechanism behind the calcium resorption is specifically the effects of PTH on the osteoclast. So it's really specific. So the parathyroid hormone gets to the bone, affects the osteoclast, which resorbs bone. So I don't think necessarily you'd get lead out of bone at the same time, but wow, what a great question. And I honestly would say from a theoretical standpoint, I don't think so, but who knows? I don't know if that's been looked at. Great question. You guys are sharp.
Okay, with that, we're going to end the session here. Thank you all for joining.
Thanks again, Debbie. Bye-bye.
Okay, bye-bye.